So, good evening, everyone. I'm Dr. Rohan Khandelwal, and I will be covering up the SS recall. This is part one. We, of course, have individual recalls also lined up. Dr. Shilpi, Dr. Nishant have already recorded their recalls. We have the CTVS, the pediatric surgery, the urology, and the GI team also recording the recalls. So all the recalls would be made available to you by individual faculties, and these recalls would be visible on the app as well. One more purpose of connecting with all of you today was to get insights regarding the exam as well. And my general discussion with postgraduates after the exam was that it was slightly trickier as compared to last year. So I personally feel that the examiner covered a lot of updates, and I mean, just analyzing the paper on a whole, I saw the GI surgery part as well, urology part also. A lot of updates, vascular surgery, a lot of updates in Bailey were asked as questions. So I again would like to re-emphasize that the go-to book for any postgraduate who's starting to prepare for NEET SS should be a combination of Bailey and Sebastian, and then you build on it by doing other books, especially for the things like urology, where these books would be insufficient. So that should be the approach. And again, it was. Seen that there were a lot of questions from the tables of Bailey and certain tables of Sebastian. Key takeaway from the exam, some of the options, so maybe the question sounded simple, but some of the options were tricky, and that made it slightly challenging for you to mark the answer. I'm not sure whether this video would be there on the Marrow YouTube channel. It will be there in the app on a later date, definitely. With that, let's start with the discussion. If you have any further questions or anything, you can just write in the chat box. Yes, one thing which was again a constant theme, as it was a continuation from last year's exam, was the statistics part. And to build on that, in Marrow, we will be adding a statistics section as well from a dedicated faculty, so that you people can understand the basics and you can get those questions correct. So starting with the questions related to trauma, there were actually 3 questions related to tension pneumothorax, and that was quite surprising. All 3 were straightforward questions which we've discussed multiple times. So this was one of the ATLS updates. According to ATLS, the site of needle insertion in tension pneumothorax in adults. So please write your answers in the chat box. If you think the options are not correct, please do mention them in the chat box. So, we can work on them, and we can get more accurate questions in the recall session and in the Q bank on a later date. If I make the PPT full screen, then I cannot write on it. So that's why I'm not making it full screen. So please read the chat. Please utilize the chat box and not the question answer screen. It'll be easier for me to follow all of you there. Second option was anterior to anterior axillary line. Okay. Anterior to anterior axillary line is what you're saying. So there was one option of 5th intercostal space mid-axillary line, and there was one of 5th intercostal space mid-clavicular line. So it cannot be 6th intercostal space, because we know the triangle of safety, the lower boundary, the base is still 5th intercostal space. So if you're saying that there was an option of 5th intercostal space, anterior axillary line, and not mid-axillary line, I would mark that as the correct answer, because that is the closest. This is the update. Okay, none of them look totally correct. That is fine, but the closest one would have been 5th intercostal space. This is the update which you can see from the ATLS manual. 5th intercostal space, slightly anterior to the mid-axillary line. So that's what I'm saying, that some of the options were tricky, but we had to mark the closest one. It certainly couldn't have been 2nd intercostal space, couldn't have been 6th intercostal space. So it has had to be fifth intercostal space. And if it was slightly anterior to anterior axillary line, if that's what you're saying, I would have marked that as the correct answer. So I get no controversies regarding that. Now, second question was a male patient with a history of uh, following which he undergoes an ICT insertion for pneumothorax. Patient has expanding subcutaneous emphysema over neck and thorax. What is the next step? So I think so. All of us as postgraduates have dealt with patients who've had pneumothorax, and we've inserted intercostal tubes in these patients. Now we know that these patients can have some bit of subcutaneous emphysema. But if the subcutaneous emphysema keeps on increasing despite ICT insertion, then we need to think about tracheal and esophageal injury. Okay, we need to think about tracheal and esophageal injury. So observation is out, puncture sites, puncture the subcutaneous emphysema is out. We have to rule out tracheal and esophageal injury because these are the two injuries which are going to present with expanding subcutaneous emphysema. And you would be able to correlate Boerhaave syndrome. Boerhaave syndrome is esophageal perforation, right? And in that esophageal perforation, one of the prominent features in Mackler's triad is subcutaneous emphysema. So if you have a patient with expanding subcutaneous emphysema despite ICT insertion, always try to rule out tracheal and esophageal injury. That would be the next step. This also, I feel, was a pretty straightforward question. Any confusions regarding this question, please? Perfect. I think so. This was right. This was another question. Chest injury with a sucking wound. Right. So chest injury with a sucking wound is an open pneumothorax. This was the third question related to pneumothorax. Okay. So this is a patient with open pneumothorax, and open and tension pneumothorax. We know first thing is needle insertion, and next step is ICD insertion. After you've done the needle insertion, you have to do the ICD insertion. So in this, if you have to mark the correct sequence, it is going to be ICD insertion, followed by we cover the sucking wound with a gauze piece and tape it on three sides. Okay. So it is not going to be taping on three sides as the first thing. The first thing is on-site management was asked. Okay. And was option D needle insertion? Was needle insertion one of the options? Fine, I understand. I didn't know about on-site management. I did not get that in the recall. That's fine. So was needle insertion one of the options? Yes or no? Okay. So if needle insertion was not there as one of the options, okay, fine. So then if on-site management was asked, then you would cover with a gauze and tape it on three sides. But always remember that even prior to doing that, you will have to do needle thoracostomy. So needle insertion would have to be done. I am surprised that needle insertion was not there as one of the options. I've dealt with such patients on site while working in a trauma unit. The first thing always is to do needle thoracostomy, then you cover, and then you tape it on three sides. So if you've done the ATLS course also, there also they will teach you the same thing. I will just show you the previous questions. Just give me 2 minutes. Let me finish this one, please. So the first thing would be needle decompression, followed by covering it up with a gauze piece and taping it on three sides, because this is going to reverse the flow of the one-way valve. We know in open pneumothorax, it is a sucking wound, right? So we have to reverse the flow of the one-way valve. That is why we tape it on three sides, but not without doing a needle insertion. So that's what I want to highlight once. Okay, quick recall of the three questions which were asked regarding tension pneumothorax. This was question number 1. And here the correct answer is going to be fifth intercostal space, anterior to the mid-axillary line. You people are saying that it was anterior to anterior axillary line as the option. If that was the case, you would mark that as the correct answer. Second question was a patient with tension pneumothorax where you've inserted an ICT. There is expanding subcutaneous emphysema in spite of inserting an ICT. In such patients, always rule out a tracheal and an esophageal injury because that would be the cause of expanding subcutaneous emphysema. And the third question, on-site management in a patient with open pneumothorax, I would go with needle insertion if that was there in the option. If not, we cover it up with a gauze piece. But what the ATLS manual says is that do a needle thoracostomy and then you cover it up with a gauze piece and tape it on 3 sides. So these were 3 questions pertaining to tension pneumothorax. Fourth question was based on a Bailey update, and I'd highlighted this in the update section. This was a 22-year-old boy with a penetrating injury to the left lower chest wall. Their suspected cardiac tamponade and systolic blood pressure was 70. Okay. Now, penetrating injury, I clearly... No, Avnindra, it's not going to be that. This is an update which I've highlighted so many times in the exam. They had asked in adults, and I've told you in adults it is changed. Okay. Adults, it is changed. It is fifth intercostal space, anterior to mid-axillary line. In children, it is second intercostal space, mid-clavicular line. Okay. So this is an update which has been covered so many times. Manish, I cannot predict whether these questions would be asked in NEET PG or not. If you want to listen to it, be my guest, listen to it. But primarily the discussion is regarding NEET SS. Okay, so this was cardiac tamponade, and this is the update regarding cardiac tamponade, which I had highlighted, which has been highlighted in Bailey as well, that in patients with penetrating injury leading to cardiac tamponade, which is the most common cause, there is no role of pericardiocentesis in traumatic cardiac tamponade, and we should straight away do a left anterolateral thoracotomy or a sternotomy for the evacuation of hematoma and repair of myocardium. So that is the update which you should be aware of. And this question was based, right? So this was regarding cardiac tamponade. So these were the 4 questions pertaining to trauma, tension pneumothorax and cardiac tamponade. Next question was a patient who was post-laparotomy, and so this was a patient post-laparotomy, and please correct me, I was talking to a few postgraduates, they said post-abdominal aortic aneurysm repair. Is that correct? Was that the question? Right. So this was post-laparotomy for abdominal aortic aneurysm, post-abdominal aortic aneurysm, and there is a concern for intra-abdominal compartment syndrome. This also we've discussed multiple times that whenever we are suspecting abdominal compartment syndrome, the surrogate way to measure abdominal pressure or the surrogate for abdominal pressure is bladder pressure monitoring. That is what we do. Straightforward question. I think so. This there's no problem regarding this question. Any doubts regarding this question? So abdominal compartment syndrome can occur after severe burns, obstruction, massive ascites, post-surgery. And these definitions you should be aware of for your exam. You have intra-abdominal hypertension, which is sustained pressure of more than 12. You have abdominal compartment syndrome, which is a pressure of more than 20 with organ dysfunction. And bladder pressure is the way to measure it. Bladder pressure is the way to measure this abdominal pressure. These are the features of abdominal compartment syndrome. And like I've told you multiple times, you can always correlate these features with the clinical features which you see in pneumoperitoneum, right? Because essentially in pneumoperitoneum also, when you put in air, the abdominal pressure increases and you'll have similar clinical features there also. And the management in these patients is that you need to correct the acidosis. You need to give fluids and you need to do a decompressive laparotomy. You need to decompress the system. Correct. So abdominal aortic aneurysm with hematoma. That was the question. Fine. So this was another question which was based on the recent Bailey updates. And this was highlighted in the revision videos and the update section as well. Which of the following points is indicative of active bleeding in splenic trauma? Okay. So was this the question? Any corrections which you would like to make in the question? What is the answer according to you people? Correct. Perfect. So what they had done to confuse, they had given free fluid in the peritoneum, right? And I spoke to a few postgraduates. They had marked that. Some of them had marked free fluid in the peritoneum. But you need to understand that any splenic trauma, you can have some bit of hemoperitoneum, right? And small amount of fluid, that is not going to be indicative of active bleeding. This was a clear-cut question from Bailey updates. It is going to be a hyperattenuating foci. This is the table from which this question was based on, and I had highlighted this. So this was the question, and correct. So Deepak, just listen to this. This is the table from Bailey which I had highlighted. Just read this table and you'll get your answer. Okay, so there are two definitions which they've added, both in splenic trauma and in liver trauma. And again, I'm highlighting this is very important even for your upcoming INISS exam. So vascular injury is one definition which they've defined as a pseudoaneurysm or an AV fistula that appears as a focal collection of vascular contrast that decreases in attenuation with delayed imaging. Right. So, Deepak, your question, yes, if there is a pre-existing injury, in delayed imaging, that area of attenuation will decrease. But active bleeding, look, they've clearly highlighted in the table itself, and the question is exactly from this line. Active bleeding, focal or diffuse, is that which increases in size or attenuation in the delayed phase. So, it's a very classical thing, a direct line which has been taken out of Bailey. Is that clear, everyone? Any doubts regarding this one? This is both for liver and both for spleen. Again, I'm saying a very important concept for you to understand even for your INISS exam. Jagdish, look, what I have read is that bladder pressure is the most commonly done and the most convenient way. I haven't read whether the best is transgastric. Give me some time. Let me check the references and I can get back to you regarding that. Okay, sigmoid colon injury. Fine. So sigmoid colon injury, a gunshot injury, sigmoid colon through and through wound. So what is the next line of management? I think so all of us have dealt with such cases as postgraduate, senior residents. We've dealt with traumatic patients or gunshot injuries with through and through large bowel injuries. Now, large bowel, there is more contamination which is there. Usually in large bowel, we are not going to go ahead with a resection and anastomosis or primary closure. Of course, observation is out. This patient is going to come with a peritonitis, and resection and anastomosis, primary closure in large bowel are usually out. So you will have to do a diverting stoma. That is what most of the students had masked. Straightforward question, which was there. Any problems regarding this question? Yeah, Prem. So the thing is that in that case, yes. Correct. So I understand where you people are coming from. So young patient. So why not then do a primary closure versus resection anastomosis? Which one would you go for then? No signs of peritonitis were mentioned. But don't you think it is very unlikely for a colonic injury to happen and no peritonitis to be there? Look, I completely agree with some of you. And this is what, we were also taught as postgraduates, that just because it's a colonic injury we don't start thinking that there is going to be gross contamination. Now, the problem is that colonic injury, if you read, right, that's fine. I mean, some people would have marked resection anastomosis, some people would have marked diverting stoma. I'm sure majority have marked diverting stoma. And if you read there, it is also that there can be in such colonic injuries, leak rates can also be high, which is why people. Gaurav, I understand. And that is why I'm saying that if the options were not correct, is what we are discussing. You are saying some people are saying young, some people are saying that there were no vitals which are mentioned. So then it's a gray area whether to mark a diverting stoma or to mark a resection anastomosis. Can you people help me with the wording of the question? Maybe that helps. Anyone who remembers the exact wording? Gunshot injury in a young patient. Shresht is saying that minimal contamination was mentioned. Is that correct? Best management is, okay, let me correct this. Best management. And you are very certain it was sigmoid. Sigmoid, everyone is sure of. Okay, fine. Right. So let's leave this up for. Let me go through more literature regarding this, given what the options which you're saying. Personally, I know what Sebastian has mentioned now, and I agree with that. Given the lack of evidence in the question, I would have personally marked a diverting stoma because there are two options which become confusing there. But let me get back to you on this question. Okay, so let me get back to you. Maybe those who've marked resection anastomosis, you're right, but let me get back to you regarding this one. Avnindra, that's what I'm saying. So primary closure and resection anastomosis both were there. Right. So the next question was a patient presents to the emergency room with a stab injury to zone 2 of the neck with a 2 centimeter area of disrupted common carotid. So laceration in the common carotid or disrupted? What was the word there? Laceration or disrupted? 2 centimeter disruption, right? 2 centimeter gap. So mean there is a significant gap, defect. Okay, defect. Fine. So we know that zone 2 is the most commonly injured zone in the trauma neck zones. You know, zone 2 is the most exposed and the most commonly injured zone. Sorry, one option was sympathetic chain block. Ligation of CCA and sympathetic chain block. Fine. So look, the such a patient with a common carotid injury would come with a expanding hematoma. You are aware of the hard signs: expanding hematoma, hoarseness, subcutaneous emphysema, air bubbling from a penetrating wound. These hard signs have also been asked in the SS exams previously. So such a patient, you would of course need to intervene. Now, what is written in Sebastian is that if you have a one, Darshak, are you sure it was diversion with PTFA and diversion with vein graft? Both the options were there. Everyone, do you agree with that? That diversion with PTFA and diversion with vein graft? So that's what I've gathered. I also did not gather that PTFA was there because that again would confuse things. Only venous graft, fine. So if it is a 1 to 2 centimeter defect, you do repair, you do end to end. But if it is a more than 2 centimeter defect, if there's a significant chunk which is missing from there, then in that case, we have to do a venous interposition graft in such patients. So that is the correct answer. Venous interposition graft would be the correct answer here. And I think so. This was, again, a very if you have a large defect, we've discussed at multiple places, you have to read, you need a graft because you can't repair under tension. There was one question regarding damage control surgery. I've not been able to get the options and the question stem. Can you help me with this one, please? Was it mean arterial pressure or systolic blood pressure? MAP more than 90. So maintain MAP more than 90, avoid hypothermia, anticipate acute coagulopathy and treat. And was there one more option regarding acidosis? Perfect. Fine. So we know that damage control surgery. So straightforward question. I think so. This is also pretty straightforward. We know damage control surgery is done when you have the lethal triad of trauma. You have coagulopathy, hypothermia, acidosis. That is when we are doing. So in these patients, we have to correct these three things. Okay. And in damage control resuscitation, we've discussed that if we keep the BP very high, then that can lead to more bleeding because the tear will increase. So the wrong option here is MAP more than 90 is wrong. You keep the question was DCR or damage control surgery? Damage control resuscitation or damage control surgery? Okay, perfect. So damage control resuscitation, I've covered up at multiple places. So we know we have to correct coagulopathy, correct acidosis, prevent hypothermia in these patients, and MAP should be close to 70, lower limit of normal. That is what we need to keep it. So MAP more than 90 is the wrong answer. This is a table in the latest Bailey regarding damage control surgery and early total care. This is how we decide. These are the criteria for damage control surgery and criteria for early total care. We know criteria for damage control surgery would include hypothermia, acidosis, coagulopathy, a very low blood pressure. But this is systolic blood pressure and not mean arterial pressure. Okay. These are the definitions for early total care and damage control surgery. Damage control surgery, we already know. And early total care is management of the patient's injury within 36 hours of the injury after a period of initial resuscitation. We know the phases of damage control surgery. This also we've discussed multiple times. And the temporary closure, which we do for the abdomen. So any doubts regarding these questions? One more question was a straightforward question, I think. So regarding the fluid of choice in a 30-degree burn patient, 4-year-old 30-degree, was this the question? So this also, I think, so is a straightforward question. In children who are young, we need to give dextrose as well. 5D was the option. 5% dextrose. Okay. So RL, only RL was there. Last option was, so what wasn't there? Albumin NS was there or NS was not there, FFP was there. Both options were there, RL with dextrose, RL without dextrose. But RL would have. Right. So these are the ATLS formulae. We know in adults it is now 2 into body weight. Although the latest Bailey still writes 4, ATLS manual says 2. Most of the guidelines, most of the burns conferences which are being held, they are talking about 2. But the latest Bailey is still mentioning 4. So which is causing a lot of confusion. Children less than 14 years, it is 3 into body weight. And infants and young adults, young children, it is 3 into total body surface area plus dextrose containing solutions which are given. Only in electrical injuries are we using the old formula of 4. Right. This was a straightforward question. all of you can answer quickly. A patient underwent treatment for carpal tunnel and nerve block was given. Effect of anesthesia lasted for 8 hours. What drug was used? I think so. Most of us are using long-acting bupivacaine after surgery to infiltrate over the skin, so that answer for the Burns question is ringer lactate. So bupivacaine is the correct answer. And if the question was which of the following has maximum cardiac toxicity, bupivacaine again has cardiac toxicity. Were there two options, RL with dextrose and RL without dextrose, or there was just one option? Both were given. And you're sure that the age of the child was 4 years. So 4 years, I will go with RL without dextrose. Okay. This is again a straightforward question. Which of the following drugs is not used for amoxiclav anaphylaxis? Now, all of you have dealt. No procaine was there. It was mepivacaine. So we've all dealt with patients of anaphylaxis and reactions. We know what all is given, what is not given. Quickly tell me, please. So chlorpromazine is not given. Adrenaline, hydrocort, chlorpheniramine, all are given. No, B is not given. B is not given. B is not used. So this also I feel a straightforward question. Moving on to the next one. So this one I felt was a bit tricky because Q-SOFA is the one which we've discussed multiple times, right? Q-SOFA is the one which we've discussed multiple times in the exam. But they had asked a question regarding SOFA, which is a sequential organ failure assessment score. And you don't, of course, need to know the details of SOFA score, the detailed values. But what they'd asked is what is not included. So SOFA includes respiration, platelets, liver function, cardiovascular, GCS, and creatinine. Total leukocyte count is not a part of the SOFA score. So last year Q-SOFA was asked in the exam. This year they've asked a question from SOFA. Again, for INI-SS, please remember the sepsis 3.0 criteria. SOFA, Q-SOFA, SIRS. These are constant questions which are asked in INI-SS exam as well in the general surgery part. So please make sure that you go through them before your exam. I had mentioned multiple times in the revision videos that ERAS will be asked. ERAS has been mentioned so many times in the latest Bailey. So there was one question regarding ERAS as well. What were the options, please? Were these the options? Readmission rate, less post-op. Less post-op infection. Decrease wound infection. D was less pain or... Look, not true is going to be readmission high. Was this one of the options? Yes or no? So if less readmission was the option, what were the other three options? And was it not true or true? This not true was asked. And so look, if I look at the options, there is shorter stay in ERAS, which is the whole purpose, enhanced recovery after surgery. There is early recovery. There is less pain, less post-op infection. The only thing which is not matching is high readmission rate. So my conversation with a lot of postgraduates, that was the option which was discussed. So I'm going to go with that. High readmission rate is the wrong option. ERAS I've discussed multiple times. ERAS is enhanced recovery after surgery. And there are certain. So, Dhaval and Gautam, what was the correct answer according to you? If not true was asked, what was the correct answer according to you? So, all are true. Was there an option? Prem, which page of Sebastian are you talking about? Colorectal section. Okay. So, look, um, fine. I will go through the colorectal section. Now, you have to see that ERAS has been mentioned at so many places in Bailey, and there is an ERAS table which has been added after esophageal surgery, after colonic surgery. Now, was that specified in the question, or was it a general question related to ERAS? General question. Again, I'm asking true or not true. Fine. So again, let me come back to you regarding this question, this one and the colonic injury question. Both the questions I would come back to you regarding this. Let I'll come back to you regarding these two, because if it is not true, and fine, let me come back to you regarding this one as well. Yes, Kishore, I agree that in certain surgeries there is high readmission rate, but then what is the correct answer is what we are trying to figure out. Let me come back to you regarding this question. Okay. So this was a straightforward question about split thickness skin grafts and full thickness skin grafts. We've discussed this multiple times. We've discussed primary contracture and secondary contracture. And we know primary contracture is which occurs immediately after harvesting the graft, which is dependent on the dermal component. So it is more with full thickness skin grafts. And secondary contracture, which is when you put the graft on the graft bed, that is inversely proportional to the thickness. So it is more in split thickness skin grafts. Metabolic demand wasn't there. It was there, right? So in split thickness skin graft, there's less primary contracture, more secondary contracture, less metabolic demand. No controversies regarding this question. About keloids, I think so. This was also a very straightforward question. Straightforward question. Keloids, there is more collagen, less vascularity. I'm asking about the options. Yes. Fine, fine. Yes. I'm asking about the options. Are the options correct? According to Bailey, it is more vascularity. There are certain books which say that there is less vascularity. Okay. Um, I have asked Dr. Shilpi to comment about this after reading the plastic surgery books. So I would leave this question, let Dr. Shilpi give the final answer regarding this based on what the plastic surgery books are saying. Look, would you agree that there were at least what I can recall and my discussions around 8 to 9 questions were there where there was a discrepancy between what Bailey is saying and what Sebastian is saying. One of the clear-cut questions was regarding complications of thyroid surgery. So if you see, Bailey writes hemorrhage, whereas Sebastian and other books are writing hypocalcemia, transient hypocalcemia due to parathyroid injury, right? So and I think so a lot of times we've discussed this, that if it was a PG exam, we will follow what Bailey says, but if it is a super specialty exam, we would go with Sebastian. Having said that, I would say that the final say would be of that specialty book. So that is why I'm leaving this question for Dr. Shilpi to answer regarding the vascularity part. We'll come to that question. Let's come to that question when we'll come to that question. Let's continue. Limburg flaps. We'll come to that question, guys. Relax. We'll come to that question. Limburg flap, rhomboid flap. We've discussed this for pilonidal sinus surgery. This is a rhomboid flap or Limburg flap, which we use for pilonidal sinus surgery. There was another question regarding lung abscess. All of the following was not there. Okay. So what all were the options? Right main bronchus is shorter and vertical. Okay, fine. All was not there. Was option A there? Yes or no, please? Option A was there. Option B was there. That's fine. Yeah, rhombic, rhomboid. Okay, that's fine. Rhombic flap. Okay, rhombic. Fine. Rhombic. Option B was a statement in the question. Okay. Was option C there? Option C was also not there. Fine. So the correct answer is A then. Right main bronchus is shorter and vertical. That would be the correct answer. We know that the right main bronchus is shorter and more vertical, which is why more aspiration is occurring on the right side. And in the supine, in the sitting position, aspiration is more common. Aspiration is more common in the superior segment of the lower lobe. And in the supine position, it is the posterior segment of the upper lobe, but overall, it is the lower lobe of the right lung, which is most commonly affected with aspiration and lung abscess formation. Is this correct? Fine. Number of lobes. One option was number of lobes. No, that is not the correct answer. I've told you the correct answer. I'll add that in the recall once. In the Q bank, that would be corrected. We'll add that point. Which craft has best 10-year patency rate? Again, I'm sure this would be discussed by the CTVS faculty, but the correct answer here was the Lima graph. Lima has maximum 10-year patency. If I'm not mistaken, it is to the tune of 80%, but I would leave it up to the CTVS faculty to talk about it. We know that Lima specifically is done for LAD, left anterior descending blockade. Yes, so best 10-year patency for LAD, that makes the question even simpler because we know that Lima is specifically preferred for LAD primarily because of a higher patency rate. Okay. So this was another question based directly on the Bailey updates, and I had covered this up in the vascular surgery updates, the Bailey updates, where I'd spoken about toe brachial pressure index as well. Okay, so this was a question regarding CTLI, and I told you that the values keep on changing. The latest values for CTLI, CTLI stands for chronic limb-threatening ischemia. Tell me the correct options, please. Ankle less than 70 and toe less than 50. And I'm not saying it. Okay. Ankle, toe less than 50. What were the other options which you said, please? Ankle 50 to 30. So A and B options are correct, right? Or B is less than 50 now. So we know chronic limb threatening ischemia, ABPI, we know less than 0.5, right? So ankle less than 50-30 was there. 50-30 was there, right? 50-30 is the correct answer. The other options you can, other options you're saying 70-50, 50-30 is done. Other options, we'll note it down from the CTLI. Guys, this is what I feel is the correct answer. Again, I'm telling you that let the CTVS recall happen tomorrow. Let them give the final answer on this. Okay. This one was from Bailey, where they had asked about management options for varicose veins. And we know that endovenous laser ablation, which is the treatment of choice, is not done if there is if the vein is adherent to the skin, because this can lead to ulceration of the skin. So that is why we are not doing this. Most of these procedures are done as daycare procedures under tumescent anesthesia. So this is correct. Cyanoacrylate glue can be done, and cyanoacrylate glue treatment is there and has been mentioned in the latest Bailey, done under tumescent or regional anesthesia. We don't need post-operative right, and needs post-operative compression. This is the wrong statement which is there. And earlier we know that SFJ and flush ligation with great saphenous vein stripping, this used to give us good results. Now we have better modalities like RFA and EVLT. Compression, we know we need to give to ensure that the vein becomes collapsed. Trendelenburg, you already know about EVLT and RFA, you people. EVLT and RFA are the latest treatment modalities. Both are done under tumescent anesthesia. A young girl whose fingers change color from white to blue to red on exposure to cold. She is evaluated for rheumatological illnesses and her screening markers come out as negative. How will you explain the prognosis to her? Was this the question? Options, please tell me the options. She has future chance of connective disorder, but they had mentioned that rheumatological illness markers were negative. She currently has scleroderma, but the rheumatological illness markers were negative. Are you sure, Ishita? Was this statement, she has a future risk of connective tissue disorder, included here? Right, so this is Raynaud's disease, which does have a waxing and waning cause, and those who have secondary Raynaud's can have connective tissue disorders. Usually, amputation is not required. It is curable. As we've discussed, it has a waxing and waning course. Surgery is not the definitive treatment. Calcium channel blockers can be used in these patients. So if Deepak, those were the options that you're saying, then B is the correct answer. If the options which you are saying are correct. So primary and secondary Raynaud's, there are two types of Raynaud's which are there. Primary Raynaud's is more common. This is usually not associated with connective tissue disorders or collagen vascular disorders. Secondary Raynaud's is associated usually with collagen vascular disorders like scleroderma. And secondary is the one which can have more complications as well. So that would be the correct answer. What I have mentioned as option A would be the correct answer. Any doubts regarding this, regarding the answer? We can debate over the options, but anything regarding the answers, please? Fine, perfect. Was there a question regarding superior lumbar hernia? What were the boundaries asked? Image was given. No, that is not the all patients of Raynaud's don't have scleroderma. They had given an image and they had asked, what will you do in clinical examination? Was that the question? Okay, what were the options? What were the options? Reducibility, reduction, cuff impulse, ultrasound. Okay, so ultrasound, cuff impulse, and relation to 12th rib. Okay, so there were groupings like this. Is Methali correct? Were there groupings like reducibility, cuff impulse, relation to 12th rib, reducibility, cuff impulse, and ultrasound for defect mapping? Were there groupings like this? Okay, so there were groupings which were there. So we know that superior lumbar triangle hernia, superiorly of the 12th rib, laterally internal oblique, medially sacrospinalis. Now, usually these are secondary hernias. You would definitely need some kind of imaging to map out these hernias because clinically they might not be very apparent. So CT was definitely not there in any of the options, right? Okay. And there was only one option which said ultrasound, where the grouping of ultrasound was there. Look, nowadays ultrasound is considered as an extension of clinical examination only. So, Methili, if they had to mention that, look, I would personally go in for, so there was one option which said ultrasound, relation with 12th rib, and cuff impulse and reducibility. No, I would not. No, ultrasound would not be the best modality. That is why I'm asking if CT was there, or the question categorically asked only clinical. So there was only, okay. Let's keep ultrasound aside. There was one option only with 12th rib. So that will be the correct answer. The option which, the grouping which had relationship with 12th rib. Fine. So the option, the grouping which had relationship with 12th rib, which was reducibility and cuff impulse, right? And so that will be the correct answer then. Now, child with an umbilical swelling, this was the second question related to, this is the second question related to hernia. Child, this was a newborn child or a, are you sure it was 10-year-old? Okay, 10-year-old child. 10-year-old child, umbilical swelling, which reduces with a gurgling sound, right? Fine. So umbilical hernia, options, surgery, CT to confirm diagnosis, observation. What was option D? Wait and watch and observation are the same thing, right? So irrespective whether the child was 4 years or 10 years, if it was an umbilical hernia, if you're saying it is difficult to reduce we are going to go in for surgery in these patients. So surgery would be the correct answer. Any doubts regarding that? We'll add that as the option. Don't worry. Once this goes in the queue bank, the team is noting down the chat options as well. We'll make it a comprehensive question when it goes into the queue bank. Don't worry. So this was a patient 4 into 4 centimeter breast lump, lower outer quadrant, axillary lymph nodes on ipsilateral side, measuring 1.5 into 1.5 centimeters. FNAC of the node is negative. Mammography shows architectural distortion and diffuse microcalcifications. On true cut biopsy, invasive ductal cancer. I just want to know one thing. This diffuse microcalcification term was there, right? Okay. So if there's diffuse microcalcification, look at this mammogram, please. If you can see such SLNB was not there in the option. Okay. So if you have such diffuse microcalcification, this is typically seen with DCIS, right? When there is extensive ductal carcinoma in situ, that is when you see this diffuse kind of microcalcification. And this is one of the clear-cut indications where we tell the patient that if there's such diffuse microcalcification or DCIS, we are not going to be comfortable in doing a breast conservation surgery because the recurrence rates are much higher in these patients. So we are not going to do a breast conservation in this case. So all the breast conservation options are out. Now, if you look at the size of the tumor, it is 1.5 into 1.5 centimeters. So it is a T1 tumor, which is N0. The lymph node was negative. T1 N0, there is no reason for us to give NACT in this patient, right? They had not mentioned the ERPR status. I'm sorry, 4 cent. I'm very sorry. Very sorry. My bad. I'm very sorry. Extremely sorry. I read it as sorry, guys. So this is a T2N0 because the node they are saying is negative. T2, not T2N1, T2N0. On basis of an ultrasound guided FNAC with no other information given, you can say it as that. So they've not given the ERPR status. Now, I've told you in the breast module that if it's a triple negative disease or a HER2 positive disease, those patients, even if it's a smaller tumor, there's more literature to support neoadjuvant chemotherapy. But nothing of that sort was mentioned in the question. And the clear-cut thing of diffuse microcalcification was for you to go away from BCS. So you could eliminate the two BCS options for this for T2N0, no particular reason for NACT until unless they are mentioning the ERPR status. So I would go with MRM as the correct answer here. You know the contraindications for BCS, diffuse microcalcification is also one of them, which indicates there's extensive DCIS, which is there. This was a straightforward question. The gene associated with familial gastric cancer. And the interesting thing is that this question has been asked in the INI-SS exam as the gene involved. So this question has been asked as the gene which is involved with lobular breast cancer and gastric cancer in the INI-SS exam. So there also you have to mark CDH1. CDH1 is associated with diffuse gastric cancer, and with lobular carcinoma of the breast. And both of them are going to show loss of expression of correct. Now, there was one question regarding skin and nipple sparing mastectomy. Can somebody help me out with the options, please? Are you saying HER2 was one of the options here? Okay, recurrence T1 and T2 tumors. No, they had asked the skin and nipples, no increase chance. So question on skin and nipple sparing mastectomy, T1 versus T2. T1, no recurrence, no increase in recurrence between T1 and T2, 50% in T2, 25% in both T1 and T2. So if it is 25, what is the difference between this option and this option? So one you're saying was that there is no difference in recurrence rate between T1 and T2. One you're saying is 25% in both. Both of them don't, option A and C mean the same thing then. Can somebody write down all the four options regarding this, please, once? So, Vaishnav, please get the options for this one. This is a question which I will get back to you regarding once I get the correct answers, questions, then options. I'm going to get back to you regarding this question because I could not get the options regarding this one. So CA breast in a pregnant female, different from normal female. Which of the following is wrong? Was this question there? So no need for mammography. This we know is true. Neoadjuvant treatment, we know that we avoid chemotherapy in the first trimester, but we can give chemotherapy in second and third trimesters, second trimester being the safest. Dilated ducts can be confused for lobular lesions during pregnancy. Mammo not done due to decreased sensitivity. No stage comparison. Worse prognosis as compared to non-pregnant female. Was this the only? So this is the false statement because stage to stage, the survival is the same. Yes, they are actually detected a bit late because there are changes which happen in the breast during pregnancy, and these lumps can be missed. So they're detected late, but stage for stage, the survival between them is the same. So that is the false statement. We've spoken about pregnancy associated breast cancers. These are breast cancers during pregnancy or within 1 year of delivery. Aggressive tumors, which are usually ERP, are negative. And if they are detected in second or third trimester, we can still do a breast conservation and they can get radiotherapy post delivery. Chemo is avoided in the first trimester, and hormonal therapy and radiotherapy are contraindicated in all the trimesters. Drug which acts both on HER2/neu and EGFR, was this question there? Yes, but the survival data has shown that stage to stage, the survival is the same. It's just that they are detected late because the pregnancy changes mask the lump. So they are detected late, but if you compare stage for stage, the overall survival is the same. So dual tyrosine cannot be. Ferrotinib, trastuzumab deruxtecan was not there. Okay. So the answer is lapatinib. Lapatinib is an oral agent, and this lapatinib was asked last year in the INI CET exam. And not last year, this year only, the INI CET exam, they had asked that a lady who is HER2/neu positive has failed on trastuzumab and has developed brain metastasis. Which of the following agents can you use? And lapatinib was there as one of the options. So one more advantage of lapatinib is that it crosses the blood-brain barrier. So even if there is a patient of HER2/neu positive, they will benefit from oral lapatinib. Okay, they are going to benefit from oral lapatinib. Now, just a few words regarding the other options, especially for those who are preparing for INISS. So adotrastuzumab is known as TDM1. Adotrastuzumab is TDM1, and TDM1 is used as a second line therapy. If somebody progresses, a metastatic patient progresses on trastuzumab, then you can use TDM1. One more utility of TDM1 is that if you're giving neoadjuvant chemo, so now we give neoadjuvant, we are using TCHP. P is pertuzumab. P is pertuzumab or Perjeta. So if with by using neoadjuvant TCHP, even after that there is residual tumor which is remaining, right? So supposing it was a 5 centimeter tumor, it has come down to 1 centimeter, but 1 centimeter is still remaining at the time of surgery. Then you know that trastuzumab normally we continue for 1 year. So in those patients, we are not going to continue trastuzumab. We will give them TDM1. So if there's residual disease post TCHP, for the rest of the year, we shift the patient on adotrastuzumab or TDM1. We don't continue on trastuzumab alone. And one more trial whose data has come out earlier this year is regarding trastuzumab deruxtecan. You know that I know it was not given. I'm just telling you for your INISS exam. Okay. TCHP is trastuzumab, carboplatin, taxane, that is usually docetaxel, and P is pertuzumab. So that is TCHP regime, which is the standard of care which is being given in the neoadjuvant setting for HER2 patients now. So one more question which has been asked multiple times: for which HER2 do we do FISH? 2 plus, correct. And positive HER2 is those which are amplified on FISH HER2 2 plus or 3 plus. They were considered as positive. But in the latest, in last year's ASCO, there was a study which was released regarding trastuzumab deruxtecan, which is used in low HER2 positive patients, means those who are HER2 1 plus also in the metastatic setting. You can use this agent called trastuzumab deruxtecan. So this is one of the latest updates which you should know about. Normally, we weren't treating HER2 1 plus, but in the metastatic setting, this is a new drug for low HER2 patients who are 1 plus. You can use trastuzumab deruxtecan. So just an update which I wanted to tell to all of you. Now, this was a tricky question because which flap for breast reconstruction has least abdominal wall morbidity? So the challenging bit was that the examiner had put DIEP right up there as option 1 or 2. That is what students said. And as I've taught you as well, that a lot of you would have marked DIEP here, which is true. When you compare DIEP versus TRAM versus muscle sparing TRAM, we know in TRAM, transverse rectus abdominis myocutaneous flap, we are taking the muscle. And when we take the muscle, there is going to be more abdominal wall morbidity. This we've discussed multiple times. And I've told you that DIEP is the best flap because there is less abdominal wall morbidity, but that is in comparison to TRAM. Now, to make options worse, they gave a superficial inferior epigastric artery perforator flap. Superficial inferior epigastric artery flap. Now, this superficial inferior epigastric artery, as the name is saying, it is superficial, right? So once we start dissecting, the SIEA you'll just find in the subcutaneous plane. So once you cut the skin paddle, you will find the SIEA just below that. Whereas for DIEP, you need to identify the perforators. So in superficial inferior epigastric artery flap, we don't even have to open up the fascia to see or the sheath to locate the perforators because the vessel is sitting right up there. So that is why least abdominal wall morbidity, the correct answer is going to be the superficial inferior epigastric artery flap, which trust me is not a very common flap which we are doing for breast reconstruction. It is being done, but more commonly and the best one which is done is DIEP. But if they are asking if these were the options, then you have to mark superficial inferior epigastric artery as a flap. Okay. If this was not there in the option, then amongst the top 3, DIEP was the correct answer. So we've discussed this. I've shown you the images for DIEP in the modules. This is a deep inferior epigastric artery flap. This was a patient with a TRAM flap. Yeah, so then the correct answer is superficial inferior epigastric artery flap. Then there was one question regarding Leaf-Romany syndrome where there were groupings, right? Guys, Leaf-Romany, are you people tired? One option was without breast. Brain tumor, adrenocortical, and sarcoma. Brain, adrenocortical, sarcoma. So this is the Chomret criteria, which is used for Li-Fraumeni syndrome. And here you can see in the Chomret criteria, you have a patient with the sarcoma, multiple primaries which are there. And so sarcoma, osteosarcoma, CNS tumor, breast cancer, adrenocortical. So out of the options which were given, which you are mentioning in the chat box, the ones which I could gather, breast, osteosarcoma, brain tumor, was this one of the options? This was not there. Brain adrenocortical sarcoma, you are saying. Brain adrenocortical sarcoma, was this there? Breast and brain were not given together. So this option is wrong. Okay, this option is out. Brain adrenocortical and sarcoma was there as one of the options, right? Then that would be the correct answer.